I'm very happy that we have Dr. Arnaul with us here today to talk about VIP, Ventilator Integrated Polygraphy. Dr. Arnaul works at the Hôpital Saint-Mus in Toulon, France, and is in charge of the intensive care unit as well as the Center for Home Mechanical Ventilation. Dr. Arnaul, very welcome, and the floor is yours.
Thank you very much, Carl. Ladies and gentlemen, good morning, good afternoon, good evening for some of you. Thank you for joining this webinar. So I really want to thank Breas to organize this education by Breas, because I think it's a great project, and I had a chance to see most of the lecture, and I think the quality is very good and the speakers are great. So I will try to be in the line. So last month we had a talk by Dr. Perrin, how to use ventilator integrated polygraphy, and we speak about the concept, but also a little bit about some cases. And today we will speak mainly about how to use it in practice, and we will see some clinical cases. So we will review shortly what are the tools to monitor an IV, what is the indication for the polygraphy, is it feasible at home, and then we will review some clinical cases, mainly in upper airway obstructions, patient ventilator synchronization, and respiratory asynergy. So let's try by how to monitor an IV. When we monitor an IV, I think that we have to look at the symptoms of the patient to make sure that the treatment is efficient and well tolerated. We have to assess the gas exchange, the daily use of the NIV, the non-intentional leaks, upper airway obstruction, and patient ventilator synchronization. So we may imagine a sort of basic monitoring package, which is the minimum that we should do when we monitor an IV. So asking a few questions to the patient to assess the symptoms. You know that a patient before an IV have symptoms of chronic alveolar hyperventilation, and after starting an IV, if we see that there is a decrease or relief of the symptom, it's a very good signal that the treatment is efficient. But also, as a patient, what is the tolerance? How long it takes to fall asleep at night, in the evening, that the patient wakes up, how does he feel or she feels in the morning, that she has headache, morning fatigue, and so on. Regarding the gas exchange, we should do an arterial blood gas during the day. Regarding the daily use, the minimum is to look at the statistics, so we can have the mean or the median daily use over a certain period of time. Regarding the leaks, we can have also the statistics of the mean, median, and 95 quartiles of the total leaks or non-intentional leaks over a certain period of time. Regarding upper airway obstruction, we can look at the apnea-hypopnea index, which is a statistics also. And regarding the synchronization, we can look at the percentage of triggered breath, which give a rough assessment of the synchronization. However, with this basic monitoring package, we can see if there are problems, but we cannot know the cause of the problem. And this is why in my practice, I use a more complete monitoring package, which is the same for the symptoms, the same questions. In terms of gas exchange, on top of an arterial blood gas during the day, we add a nocturnal recording, either nocturnal oximetry or a nocturnal transcutaneous capnography, or a combination of both. Regarding the daily use, I think the statistics is probably not enough. We should look at the detailed daily use, meaning does the patient use the NIV every day, at what time during the day, during the night, how many sessions, and so on. Regarding the non-intentional leaks, we should look at the overnight leak profile that gives you some indication of what is the cause of the leak, because there are many different causes. Regarding the upper airway obstruction, the obstruction index is not always fully accurate, and we may have a look at the flow curve. And regarding synchronization, we can look at the waveforms. So the usual waveform monitoring associate the trigger. I like to put the trigger color code on the top. So green means that the breath was triggered by the patient, and yellow that the breath was triggered by the ventilator according to the backup respiratory rate. Then we have pressure, patient flow, and total leakage. Just to remind you that the total flow is the raw measurement of the flow that is measured at the ventilator output, and the total flow is splitted by the software into patient flow and total leakage. So the blue curve plus the red curve give the yellow curve. So when you interpret the curve, you can either look at the total flow, and then when there is a leak, you will have an increase in the baseline of the flow, or look at the patient flow and the total leakage. It's up to you. That's the same information. However, when we look at the curve, it's not always easy to see the patient effort, when the patient effort starts, and especially when the patient effort ends. And this is why, in some cases, we may imagine an advanced monitoring package, which is to add the effort belt to the complete monitoring package. And the effort belt will be very useful to assess and characterize the upper airway obstructions, and to characterize also the patient ventilator synchronization. So now, on top of what we have already seen, there is the SpO2 and the effort belt. The pink, there are two belts, one on the thorax, one on the abdomen. The thoracic belt is the pink one, and the abdominal is the dark blue one. So when should we indicate a polygraphy? Well, if we look at the common troubleshooting in an IV, the most common one is probably non-intentional leaks. And to diagnose and to manage non-intentional leaks, we don't need a polygraphy. We just look at the monitoring and reassess the interface or add a shin strap. Now, the second problem is probably the upper airway obstructions. If we detect upper airway obstruction on an IV, most of the time we will try to increase EPAP, or if we believe that the obstruction is due to the mask, that is, have too much pressure in the lower part of the face, then we can change the interface. The third one is probably the persistence of a nocturnal hypoventilation that we can probably detect by a nocturnal oximetry or transcutaneous capnography. And in this case, we should increase IPAP or increase the backup respiratory rate or use a target volume. And the last one are patient ventilator asynchronous, which are very common in an IV. And in this case, we should adjust the triggers and sometimes the rise time. However, if this first line treatment is not efficient or not efficient enough, and we have persistent troubleshooting, I think this is a good indication to use the polygraphy. So in my experience, the polygraphy is not something we have to do in every patient systematically. It's more a second line monitoring that we do after a first trial to solve this problem. If we are not able to solve it, then the polygraphy will help a lot. So what is the feasibility? Can we do it at home? There is a very nice recent paper on this topic where it was done by a Polish group of researchers. The objective was to assess the feasibility of a non-supervised complex monitoring at home. And what they call complex monitoring is the combination of a polygraphy and a transcutaneous capnography. So they included 18 patients that were on home NIV for more than 1 year, considered as stable. And the setting of the monitoring device, and the education was done by a nurse that went home to see the patient, and the nurse put or installed the Centec capnograph, a NOx polygraph, and a nonin SpO2 sensor. And then they evaluate the feasibility. They consider the feasibility as excellent if they were able to analyze, if the analysis time was equal to 100% of the recording time, meaning there is no loss of data. The feasibility was considered as good when they were able to analyze more than 80% of the recording time, fair between 60 and 80, and poor below 60. So they include 18 patients, mostly with kyphoscoliosis, obesity, hyperventilation syndrome, and COPD. This patient had a very nice or very good daily use. These are the results. Regarding transcutaneous capnography, out of 18 patients, you may see that 14 had an excellent or a good feasibility, while 4 had a poor feasibility, which is a little bit more than 1/3 of the patient. Now, regarding polygraphy, the thoracic or the abdominal belt, the results were very good, with most of the patients except one that had an excellent or a good feasibility. Same for the pulse oximetry and same for the flow sensor. And they calculate that there was no difference between the patient living alone or within family members. So for me, the message of this study is exactly my experience, that doing a polygraphy, a non-supervised polygraphy at home, is not that difficult. What is difficult is to do transcutaneous capnography, and we know very well, it's published, that the failure rate of the transcutaneous capnography is somewhere between 30 and 50% when it's done at home. Now, if you use a polygraphy that is connected on the Vivo 45, it's even easier than with the NOx, because you don't need to add a proximal flow sensor. The ventilator will use the flow sensor, the usual flow sensor. So the patient just have to set a thoracic belt, an abdominal belt, connected with some cables. These cables are connected to a small box, and this box is connected to the back of the ventilator. So it's very easy to explain, and we give a small hands-on to the patient. And you add an SpO2 sensor, and in my experience, there is very little failure. The only failure that we may have sometimes is when the patient does not tie the belt enough, then we have a loose signal, and we are not able to interpret. So let's see some cases. Just to remind you, when the open airway, when the upper airways are open, what the signal will look like. So as you know, the diaphragm is the main inspiratory muscle. So when we breathe, the diaphragm goes down so that the diameter or the size of the abdomen increase, and the air come in the thorax, so that the diameter or the size of the thorax increase. So when you have a normal inspiration, you will see an increase in the signal of both the thoracic and the abdominal belt. Now, when the patient exhales, it's the other way around. The diaphragm goes up, which means that the size of the abdomen will decrease, and the air goes out, which means that the size of the thorax will decrease. And this is why we have, during expiration, a decrease in both the signal of the thoracic and abdominal belts. Well, when we have an increase in the signal, it may mean that the patient is doing an inspiratory effort, or that the patient gets a passive breath. It's not always easy to distinguish, because in both cases, of course, the size of the thorax will increase. So how can we see it in detail? If we compare a breath that is triggered by the patient, so a green colored breath, you will see that the thoracic belt will increase first and the ventilator will deliver the pressure later, meaning that the breath starts by an inspiratory effort. While if now the breath is triggered by the ventilator according to the backup respiratory rate, it's the other way around, meaning that the ventilator will start to deliver the pressure and then the pressure will increase later as a consequence. Now, what about if the upper airways are obstructed? When we have upper airway obstruction, then if the patient is doing some effort, the diaphragm will go down, so it will increase the size of the abdomen, but now there is no air coming in because of the obstruction, so the size of the thorax will decrease. And this is what we will see if we have some effort during an obstruction. We will see an increase in the abdominal belt and a concomitant decrease in the thoracic belt, which we call a paradoxal movement. And sometimes we see that there is absolutely no effort during the upper airway obstruction, which suggests that there is a decrease in the respiratory drive that may be the cause of the obstruction. So let's see a case. Mr. Giovanni, 67 years old, he is treated for an obesity hyperventilation syndrome, BMI 36. He's ventilated on a Vivo 45 with a facial mask. The EPAP is 6, the IPAP is 16 centimeters of water. So again, the color code, green is patient trigger, yellow is ventilator trigger. Then we have pressure, flow, total leaks, SpO2, and the belt, pink for the thoracic belt and dark blue for the abdominal belt. So as it was explained last month by Dr. Perrin, to interpret this curve, first we have to look for a decrease in the SpO2. So you can see here a decrease in SpO2. Then we have to go a little bit back and look for some event on the patient flow. And here we can see, yes, there is an event with a decrease in the inspiratory flow and a decrease in the expiratory flow at the same time. Well, to conclude about this event, we have to look at the leaks. So here we see there is no increase in the leakage, so it means that this event is an upper airway obstruction. Be careful, because you may have exactly the same shape on the patient flow, but if we have a leak, then it's just due to the leak. Okay, but here there is no leak, so it's an upper airway obstruction. And then we will look at the belt to see if the patient is doing some effort or not. I will focus a little bit on the belt. And here you see that at the beginning of the obstruction, there is not much effort, but then at some point we have effort from the patient with an increase in the abdominal belt and a decrease in the thoracic belt. So we can conclude that it's an upper airway obstruction with effort, and the diaphragm is good because you see that the effort is nice. Okay, a large increase in the abdominal belt, so it means that the diaphragm strength is good. So in this case, to prevent this event, we have to increase EPAP. Now another case, Jean Marc, 60 years old, is treated for an amyotrophic lateral sclerosis, facial mask, same setting as previously, 6 of EPAP, 16 of IPAP. Again, we will look at the decrease in the SpO2. We look at one event. So again, we have a decrease in both inspiratory and expiratory flow. There is no leakage, so it's an obstruction. And we look at the belt. And again, there are some movement during the curve. We will zoom in. There are some movements during the obstruction, but now it's not the same as previously. You see that the movement are an increase in the thoracic belt and a small decrease in the abdominal belt. So it's a reverse as previously. So we conclude here that it's an upper airway obstruction with some effort. But now there is a diaphragm weakness, meaning that the patient is doing effort with the accessory muscles. However, the solution to prevent such obstructive events is to increase EPAP. So to resume, when we have an upper airway obstruction, if the diaphragm is efficient, the diaphragm will go down and we will have an increase of the abdominal belt, a decrease in the thoracic belt. This is what we saw in the first case. In the second case, when the diaphragm is very weak, the patient will do the effort with the accessory muscle. So it will increase the thoracic belt, but the diaphragm will move up, so it will decrease the abdominal belt, and this is what we see here. And sometimes we have this kind of patient, Mr. Robert, 63 years old, treated for an ALS, also 6 of EPAP, 19 of IPAP. We see a very nice decrease in the SpO2. Then we look for the event. We see that there is again a decrease in the flow. So it's an obstruction. Let's look at the leaks. There is no leaks, so it's an upper airway obstruction. But now if we look at the belt, there is absolutely no effort on the belt. Okay, if we zoom it, you see it perfectly. So it's an upper airway obstruction with no effort. So it means a decrease in the respiratory drive. So how can we manage such events? First, we have to look if the decrease in the respiratory drive could be due to hypocapnia. You know that if we hyperventilate the patient, we may have hypocapnia, and we know that hypocapnia promotes the decrease in the respiratory drive with some kind of central apnea. So this is why we would perform a transcutaneous capnography in this case. If we found that the patient has hypocapnia, we will decrease IPAP or decrease the backup respiratory rate in order to correct the hyperventilation. But sometimes there is no hypocapnia, or we are not able to demonstrate it. And then in this case, we may try to stabilize the airway just by increasing EPAP. To be very honest with you, it's not always efficient. Sometimes it could be, but not always. So just to give you an example, sometimes when you do a transcutaneous capnography, you see in this patient that the patient start the night with around 37 millimeters of mercury of transcutaneous CO2, and as soon as they use NIV, the CO2 goes down, and he spends most of the night with a very low CO2. So in this case, it may promote a decrease in the respiratory drive and this kind of central apnea. This was not the case in Mr. Robert. We performed the transcutaneous capnography and we didn't find hyperventilation. The patient remains slightly hypercapnic during the night, so we decided to increase EPAP. Let's move to the patient ventilator synchronization. Mr. Ahmed, 58 years old, is treated for a COPD with a Vivo 45, facial mask, EPAP 8, IPAP 24. And here on the flow waveform, you see this strange thing that the patient starts the inspiratory effort here when the flow changes, but he gets the inspiratory or the mechanical breath here. So there is a delay between the effort and the mechanical breath. And if you look at the belt, it's very nice because you see first the abdominal belt that increase, meaning that the diaphragm is working correctly. But because there is no air coming in the thorax, we have first a decrease in the thoracic belt. And as soon as the mechanical breath starts, then we have a secondary increase. So this is called inspiratory trigger delay. So there is a delay between the beginning of the effort of the patient and the mechanical breath, and it could be very uncomfortable for the patient. So in this case, we have to increase the inspiratory trigger sensitivity. And you will see in the detail of this patient, the inspiratory trigger was set at 6, which is not sensitive enough. Don't ask me why. So in this case, by increasing the inspiratory trigger sensitivity, meaning setting at 1, 2, or 3, we will solve the problem. Another case, Mrs. Annie, 68 years old, treated also for COPD, EPAP 8, IPAP 19. And you see on the flow curve, on the expiratory flow curve, a sort of distortion to the baseline here. And in the same time, you see very small effort on the abdominal belt and a very small decrease on the thoracic belt. So what is this? This is an ineffective inspiratory effort, meaning that the patient is doing an inspiratory effort that is not able to trigger the ventilator. So it's very common in NIV, mainly in COPD and neuromuscular disease patients. If we found ineffective inspiratory effort, we should again increase the inspiratory trigger sensitivity. So in this case, it was 3. So we had to use 2 or even 1, the most sensitive possible. If it's not enough, we may decrease IPAP in order to reduce intrasec PEEP. And by reducing intrasec PEEP, the patient will be more prone to trigger the breath. And we may also increase EPAP so that EPAP better match the intrasec PEEP. Another case, Cathya, 30 years old. She has a myopathy. She's treated with a facial mask, EPAP 4, IPAP 16. And here we see on the pressure waveform a sort of strange breath that is coming too early. We would expect that he would come later. And is very short as compared to the normal ones, okay? If we look at the flow, we see that there is very small inspiratory flow. And if we look at the belt, there is absolutely no change in the belt, meaning that there is no inflation of the thorax. So what is this? This is an auto trigger, which means that the breath started by itself just because of a small leak or because the inspiratory trigger was too sensitive. And obviously, when there is an auto trigger, there is no inflation of the lung. So in this case, we should decrease the inspiratory trigger sensitivity. See, it was set very sensitive at 1, so we changed for the setting 2. Mr. Ahmed, again, the same as before, COPD. Now we look at the expiratory or the cycling asynchrony. Here you see a very strange expiratory flow. Usually the expiratory flow goes down, has a sort of triangular shape. Here there is no triangle. There is a sort of decrease of the peak expiratory flow with a distortion here. And if we look at the belt, we see actually that the effort of the patient is prolonged beyond the mechanical breath. So it's obvious that the patient effort lasts until here, but the mechanical breath stops earlier or cycle earlier. So it's called an early cycling when the breath stops too early as compared to the patient effort. And it's not comfortable at all. And to fix this, we have to prolong the expiratory trigger just to make sure that the mechanical breath match the patient effort. So here the expiratory trigger was very short, setting number 2. So we should prolong it by setting at 3, 4, or 5 maybe. And in the same patient a little bit later, we have this shape, which is start with a normal breath, but the first breath is very short, and then the patient is able to trigger a second breath. And if we look at the belt, we realize that actually the patient is doing one single effort, a quite long effort. So it's one patient effort that triggers 2 breaths. So it's called a double trigger. And the cause of the double trigger is an early cycling. The first breath is so short that the patient is able to trigger a second one. So it's more or less the same problem as before, and the solution is the same. We should prolong the expiratory trigger sensitivity. And the reverse is here. Mrs. Cathya, again, here on the flow curve, we see that the slope of the flow will change at some point, meaning that the effort of the patient will stop here. And all this time is extra time, meaning the patient would like to exhale here, but gets this time with insufflation. So there is an asynchrony here, and we see on the belt that the patient starts to exhale at this point. So it's called a delayed cycling, meaning that the mechanical breath is longer than the patient efforts. And this is not comfortable at all. So in this case, we should shorten the expiratory trigger to make sure that the mechanical breath is shorter. Here, the expiratory trigger was set at 9, which is very long, so probably we should change it. Another reason could be leaks. If we have unintentional leaks, sometimes the flow, inspiratory flow, goes to the leak, and this is why the cycling criteria is not achieved. And in this case, we can use a TI max to stop the insufflation time. Let's finish with the respiratory asynergy. So it's less common cases. Mr. Jean-Pierre, 78 years old, treated for an ALS also. He's at the beginning of the treatment, so quite low pressure, EPAP 4, IPAP 11. And here we see a very strange thing on the belt. If you look at the insufflation, during insufflation, we have an increase in the thoracic belt, but a decrease in the abdominal belt. And we would not expect a decrease. So why do we have a decrease in the abdominal belt? It means that the diaphragm is very weak and the effort is done with the accessory muscle. So let's look how it works. Here the patient has a very weak diaphragm, so he's trying to pull with the accessory muscle. So we have an increase in the thoracic belt and a concomitant decrease in the abdominal belt. So it's called a respiratory asynergy. There is no occlusion, the flow is normal, it's during normal ventilation. What can we do? Well, we cannot do anything, it's just an information that we get that this patient has a very weak diaphragm, but there is no way to fix it. So there is no change on the ventilator. So to resume all this information, the common troubleshooting are upper airway obstruction, and for this, the diagnostic value of the polygraphy, I think, is very interesting because we can characterize the mechanism of the upper airway obstruction with or without effort, and the therapeutic value will mean that we have some settings to change, but it's not the same setting that we have to change if it's an upper airway obstruction with or without effort. So I think the clinical value is important here. Regarding patient ventilator asynchronies, well, to be honest, if you know very well how to read the curve, the belt will not bring too much information, but if you are not comfortable with the pressure and the flow curve, then the belt will be very helpful. And if we see some asynchrony, of course, we have to change the setting, so the clinical value is quite important. And regarding respiratory asynergy, well, it's very nice because we can diagnose it, but there is no therapeutic implication, so the clinical value is less. So my conclusion is that polygraphy is an advanced monitoring tool, maybe not for every patient, but as a second-line monitoring tool. We can use it in case of complex upper airway obstruction, asynchrony, and persistent hypoventilation. There is a good feasibility to do it at home. We don't have to ask the patient to sleep in the hospital to do this. And the clinical value is mainly to characterize the upper airway obstruction, to assess patient ventilator synchrony, and to diagnose the respiratory asynergy. I thank you for your attention. The next meeting, I was asked to announce the next meeting. So the next meeting next month will be very exciting topics, how to perform airway clearance in the ICU. And the expert, it's really an expert in this topic, will be Miguel Congalves, who is working in Porto, in Portugal. So it will be the last Thursday of November, same place and same time.
Thank you very much, Dr. Arnaud, for a very informative talk about a complicated topic. But I think with the nice introduction and all the examples you gave, I think you really clarified it down to the details. We do have a number of questions that came in during your presentation, but I also invite everybody that has a question to drop it in the Q&A chat as we speak. There is a couple of questions which I will pull together because it's basically the same question, but it shows the different approach around the world. Because there is one question where they ask that the Breas system is rather easy to use in the hospital outside the sleep lab, and if that is what you would like to do. But on the other hand, there is also a question where they ask if the Breas device can be used in the sleep lab and be integrated in systems like Alice 6 or any other PSG system. So one is looking to use it outside the sleep lab and others inside the sleep lab. So interesting question. What's your opinion?
So yes, of course, we can use it inside the hospital, not in the sleep lab. I use it in the step-down unit from time to time, and the feasibility, even for a non-expert nurse that are not familiar to supervise the sleep of the patient, then the feasibility is really good. We always have a very good result. Now, the connection with the existing polygraphy, I don't use it, so I don't know how to answer to this.
Yeah, I can answer the question from my side. At the moment, there is no integration from the Breas Vivo 45 or 45 LS within a polygraphy or a polysomnography system, which is being used in the sleep lab. So that connectivity at the moment is not there yet. Another question, if one night of recording with effort belts is sufficient, or what do you advise, or what is your practice?
What we do when we record one night is that we ask the patient a few information. Of course, what are the conditions of use? Was it on NIV with oxygen, without oxygen, and so on? What was the time of sleep? If he wakes up during the night, we want to know at what time. And we ask, how was your night? Is it a normal night or really bad night? If the patient say, well, it's a night like usual, then we don't repeat it because we consider that one night is enough. Of course, if the patient describes special trouble during this night, then we may repeat it because we assume that probably the second night will be different. But in most of the case, we do only one night.
Okay, thank you. There's two questions related to the upper airway obstructions, which you have shown us. One is, in your experience, how common are upper airway obstructions? And linked to that, maybe, are there certain patient populations where one should be more careful and have pay more attention for it?
That's a very good point. You know, before I use it, upper obstruction is quite common in obese patients. So obesity, hyperventilation syndrome, or overlap syndrome. It's pharyngeal obstruction. We are used to it. We are used to deal with it. Now, by using polygraphy, I realized that upper airway obstruction are really, really common in neuromuscular diseases, especially in ALS. And if you only look at the statistics, or if you look at the flow curve, we are unable to see if it's an obstruction due to the pharynx or due to the larynx. And they look like the same on the flow. And by using the polygraphy, I realized that the laryngeal obstructions are very common in ALS, much more than what I thought in the past, which is clearly a problem because now we are very careful about our setting and we are more careful about this.
Okay, thank you very much. Yeah, a statement and a question. One of the attendees says, well, the more we monitor, the more we will probably find. Do we need to correct everything?
Yeah, it's true. The more we monitor, the more we find, for sure. If we don't monitor, everything is fine. You know, I would say even if we do our best, the quality is still suboptimal most of the time. So my point is that when we found something, of course, we have to evaluate the importance. You know, does this problem disturb the patient? For example, if we have an asynchrony that is so uncomfortable that the patient takes some time to get to sleep, of course we have to fix this problem. Or if we have obstruction and the patient wakes up every 2 hours, of course we have to fix it. Now, if you have some asynchronies and the patient does not complain about anything and describe that the sleep quality is very good, do we have to correct it? In my opinion, if it's easy to correct, why not? I try always to do my best, but even when we do our best, we still have a lot of asynchronies, we still have a lot of leaks that we cannot manage, we still have a lot of ineffective effort that we cannot manage. And my point is that even if the patient does not complain, if you let some asynchronies running, at some point the patient will feel that the ventilation is less efficient because it's less comfortable, and slowly, weeks after weeks, you will see a small decrease in the daily use, and this is not good, of course. So I try to correct as much as possible, and even by doing this, we are far from being perfect.
Okay, thank you. Last question which came in, it's about the monitoring at home. I think it has been maybe already answered, but we know that the patient can handle the SpO2 sensor, but what about the effort belts and the transcutaneous CO2? What is your experience, is the question.
Well, in my experience, the most difficult is the transcutaneous CO2. Meaning if we have a single patient that has to put himself the sensor and so on, the failure rate is very high because it is complicated and very sensitive to, you know, everything, I would say. Polygraphy is much easier, as it was described in this study, and SpO2 is much easier, providing that we fix a sensor with something on the finger. Okay, thank you. That was the last question which came in. Let me have a look. Yeah, there's nothing else came in. So with this being said, I would like to thank Dr. Arnal very, very much once again for this clear explanation and also his practical experience, day-to-day experience on using this kind of tools in his daily practice. Thanks a lot, Dr. Arnal. Thank you everybody for joining this webinar today.